to share ideas and collaborate with colleagues from across the country on a topic area that interests them. If you're interested in joining this group, the Digital Health Interest Group, you can get in touch with Christine, who emailed you and provided you the link today, or visit the CNEI website through CASN. Now I'd like to introduce you to today's presenters. Carly Whitmar and Marissa Bird are both registered nurses and PhD students in the School of Nursing at McMaster University. Marissa is studying digital health interventions for children with medical complexity and their families. Marissa's work focuses on enabling children with medical complexity to be cared for safely at home by leveraging digital technology to connect families with healthcare providers remotely. Her doctoral research is supported by a CIHR Frederick Banting and Charles Best Doctoral Award, as well as the Norman Saunders Complex Care Initiative, Division of Pediatric Medicine, the Hospital for Sick Children. Carly is a Vanier Canada graduate scholar whose research explores health narratives of community dwelling older adults with depressive symptoms and other chronic conditions. Carly is a certified psychiatric and mental health nurse who is passionate about programs and policy that optimize health systems and support aging in place. She is currently training in the Aging Community and Health Research Unit at McMaster University and is the co-lead on a CHR-funded grant examining Canadian longitudinal data and the role of multimorbidity resilience in shaping perceptions of health among older adults. For those of you just joining us, welcome. I will now turn things over to Carly and Melissa.
Right, I'm going to share my screen. Okay. So thank you everyone for joining us today. We're really thankful to have you all here and acknowledge the time that you're taking out of your very busy schedules at this time of year to join us. Marissa and I are going to be presenting today on the recommendations for educating future nurse scientists to lead effective digital health interventions. This work is based on a review that we completed earlier this year, which seems like a different world and a different time. But we're really looking forward to discussing with you what this all means for nursing and for nursing science.
Carly, I'm sorry to interrupt, but I'm wondering if you could make your slides full screen.
Are they not full screen? Okay. They're showing as full screen for me.
We see the presenter view, Carly.
Okay, let me fix that then. My apologies. How's that?
Perfect.
Thanks, everyone. So as Jody said, my name is Carly Whitmore, and I'm joined here today by my colleague, Marissa Bird. We've included our Twitter handles here on the screen. We love to connect with people. And so if you're interested in chatting with us about this topic further in the future, please follow along with us. We're also pleased to have the support of our funders, as well as the ongoing support of the School of Nursing. As settlers, we acknowledge the traditional territories upon which each of us gather today. For us here at McMaster University and in Hamilton, Ontario, the site in which Marissa and I are privileged to advance our nursing education and our understanding, we are located on the traditional territories of the Mississauga and Haudenosaunee nations. These lands and resources around the Great Lakes are protected by the Dish with One Spoon Wampum Agreement, which is pictured here on the screen. In this wampum, the dish represents the shared land and resources, and the spoon reinforces the idea of sharing in peace. To say this acknowledgement is to acknowledge the debt to those who we are here before us, and as settlers to recognize our responsibility and to honor and respect these agreements. In recognizing that you're all joining us from various locations, we ask that you please just take a moment to acknowledge the land in which you are situated.
Thanks, Carly. So to start our presentation, we thought it would be important to situate ourselves in our current context, and that is one of a global pandemic. I think it's fair to say that COVID-19 has changed things for all of us and has probably forever changed the way that healthcare will be delivered. We certainly have seen a dramatic rise in digital health interventions, and this for us has highlighted the need for flexibility in caring for those managing both chronic and acute conditions outside of traditional spaces for healthcare delivery, and bringing this healthcare delivery into patients' homes and communities. So we believe that nurses are crucial to the success of this movement. And this was the impetus for us completing the review that we did, the findings of which we'll share with you today. So over the next hour, alongside presenting the findings of our completed review, we plan to suggest some questions for us to think about as a collective. And we're really hoping that you'll consider participating in some of those discussion questions as well, so that we can have a nice, robust discussion among all the experts who are with us in this virtual space. And in so doing, our two objectives that we hope to achieve today are to gain an increased knowledge and understanding of digital health intervention research led by nurse scientists, and an understanding of the impact of these interventions on chronic condition support and management, as well to discuss recommendations for future nurse scientist education in the design and implementation of digital health research. Thank you again for joining us for this presentation.
We would be remiss to not mention that the work that's being presented here today is a product of some excellent collaborations. And we particularly want to thank the leadership team at the School of Nursing at McMaster. And this includes Dr. Sandra Carroll, Michael McGillian, Nancy Carter, Joanna Perazzo, and Ruth Chen. We also particularly want to thank the CASN team for agreeing to host this session with us today. And really, one of the things that we want to bring across is this need for collaboration. Thinking about digital health research and digital health interventions in nursing science, there's this real need for intentional intra-professional, interprofessional, and intersectoral work.
And so as a means of breaking the ice and hopefully getting us primed for some more discussion later on, I'd like you to consider the following question. So why are you passionate about digital health research? And while you take a moment to consider that, I can share with you one of my examples. So again, as was said earlier, my work is with medically complex kids and families. And so for me, digital health tools serve as a means to better connect these families to their healthcare communities. And this ultimately affords them more options for receiving care, so in their location and time of choice. I think particularly for families managing lifelong conditions, it's important to meet them where they're at and give options for care, and digital health tools serve as an effective means of doing that. So if you'd like to participate, again, you could type your question in the Q&A or the chat, or you could raise your hand and we could happily unmute you as well.
I think I saw a couple people. I just can't see them because I am full screen here.
Oh, I have not seen hands.
Okay.
Hi, it's Jody. I just put in the chat, improving patient access and outcomes.
Ah, great, thank you. Yes, there we go. Okay, improving patient access and outcomes. Thank you so much, Jody. And from Nancy Carter as well, providing opportunities for new models of care led by nurses. That's great, having nurse leadership at the forefront. I'll just keep reading these if that's okay while they come in. So from Barbara Davies, digital health is an important aspect to deliver care in Northern Ontario. Increasing access is a big part of that.
Yeah. Marissa and I particularly were talking about equity and thinking through some of these components, and that's a good one.
Great. Does anyone else have contributions, or you could think on it as well and we can talk about them as we go. Oh, one more, Eric. Great opportunity to transform care and shift from paper paradigm to optimize clinical practice. Yes, absolutely. So streamlining clinical practices as well, for sure.
I like the paper paradigm. Yeah.
Yeah.
Okay, fantastic. Thank you, everyone. So as some background, let's first talk about chronic condition management. This is sort of one of the first components of our review. And so we know that about 35 to 55% of individuals, of adults, have at least one chronic condition. And for these adults with chronic conditions, care often spans multiple health settings. And this includes acute and rehabilitative care, as well as additional sectors like the insurance sector, the supply and management sector. So in this spanning, this only increases as individuals have more and more chronic conditions. And so regardless of these settings and sectors, it's been demonstrated that care that is targeted towards episodic exacerbations of chronic disease, being that traditional face-to-face care delivery, often falls short of the needs of individuals and their caregivers. And it's for this reason that the traditional means of care delivery for chronic conditions is really no longer sufficient for individuals. And there is a need to advance and think through other alternatives to maintaining health.
And so that's where we see digital health really coming into play here. So first, a definition. So what is digital health? So digital health interventions encompass a broad array of information and communication technologies. And we can use these technologies to both facilitate access to care, as was said earlier about maybe rural or remote areas, and they can also help to deliver care as well. And this is particularly useful in those managing chronic or complex diseases where, again, we need frequent touch points along the way to help patients manage those conditions. So we've seen in the literature numerous examples of where digital health tools can be employed to assist in management of chronic conditions. And some benefits that we've noted are that digital health can help to simplify condition management. It can enhance the quality of care experienced by patients. It can enable information sharing between patients and their providers, which is absolutely huge for those managing chronic conditions. And it can also improve patient outcomes, access to care, and smoother transitions between care settings, such as those from hospital to home. So we've seen where digital health tools can be used to provide evidence-based care that's also cost-effective and a customizable solution that can meet the needs of our patient populations.
And so one of the things we wanted to highlight was that the connection between technology and chronic condition management is not new. In fact, over the last 100 years, there's quite a few examples in which technology has been used to support individuals as they treat and manage their chronic conditions. What is particularly exciting about this point in time that we're at, however, is the ways in which digital health technology, a burgeoning field and trend in health research and healthcare delivery, is aligning to this increasing trend of chronic condition prevalence, multimorbidity, as well as a drive in home and community care. And so what this means is that while there's two trends that are occurring in parallel, there really does exist an opportunity to harness the two trends and for nurses to be at that merger point in these two roads running alongside one another.
And so to take that a little bit further, we wanted to know, so where do nurses fit in this intersection between digital health and chronic condition management? And one thing we do know for certain is that nurses are well positioned to not only facilitate comprehensive clinical care for those managing chronic conditions. That's been shown time and again. But also, we believe, to design and deliver digital health interventions that respond to the complexity of these interventions, or sorry, of these chronic conditions. So we have the potential, and this is something that's really exciting with digital health, to increase what we call the nurse dose available to patients. So moving from those care management pathways that focus on acute and episodic care to integrating nurse-led care into patients' daily lives. And we can do this by providing more frequent and intensive touch points. So to give examples, this would be something like a nurse connecting with a patient, perhaps via a brief video call while the patient's at home, avoiding a trip to the hospital and the resources associated with that. It could be patients logging their own health information from home via remote vital signs management, and nurses being able to review that asynchronously using digital health on a periodic basis. So we have this opportunity now to actually increase the impact of nursing by increasing this nurse dose. And so what we asked then is, if nurses are well positioned to lead this work, and we believe that they are, how do we then educate our future nurse scientists with the requisite knowledge and skills that they'll need to lead this work? And that's where we get into what our review is all about, which I think we'll take you through next.
Yeah, and so to begin to understand that question, we completed a rapid review in order to summarize the outcomes that are commonly measured, the designs that are commonly used, and the results of those intervention studies. The hope was that in bringing all of this information together, and in consideration of our own educational stage and space, we would be able to pose some recommendations for education of future nurse scientists. And so this review included studies that were conducted by a nurse as the principal investigator, described an outcome of a digital health intervention, and included any patient population across the life course. So we weren't too picky on that, so long as the population was described as having a chronic condition. And so this publication is available now. It is out, and we are happy to share that if you connect with us. So before we launch into actually sharing some of the findings from our review, we wanted to ask you, as educators, as digital health enthusiasts, if you've been involved in digital health research, and if so, what that included. And then further to that, when Marissa and I initially conceptualized this study, this wasn't the climate we were in, but thinking through how COVID maybe has amplified a need for digital health intervention research, and specifically a need for nurse scientists to lead this work. I know myself in the last few months have had some interesting touch points with the health system through digital means. So much as having my laser eye surgery, the pre-op appointment was over Zoom. And so I think there's been some fantastic change, and we're curious to know examples from all of you.
So another example, I'll just wait while people take a moment to think about it as well. There is a study led out of Hamilton, Ontario, McMaster University, and the Population Health Research Institute as well, which we did looking at remote patient management for post-op surgical patients, where we used digital health means to monitor patients remotely at home. And that was intended to clear some space for patients utilizing the healthcare system as a means of responding to COVID. So certainly I think the COVID-19 pandemic has brought to the forefront some of our limitations naturally that we'll experience in terms of space, bed space, and healthcare resources as well. And so caring for patients in their homes as much as safely possible allowed us to kind of decant our hospital wards a little bit to prepare for those waves of COVID patients coming in. I do see there's a message in the chat from Nancy Carter. I have been involved in student research with pediatric care. I should disclose that Nancy is also one of my committee advisors and has been instrumental in my doctoral work as well, and others as well within the School of Nursing at McMaster University. So absolutely.
Hi, it's Jody. I just came off mute, but I'm just exploring the possibilities working with a virtual reality company. So as an educator working on mother baby unit with clinical groups, taking the whole clinical group to do an infant assessment, say we can't do that anymore because that's too many people in a room.
Right.
So doing the 360-degree video, and this way the students can put on the Oculus or whatever it is, but they can be immersed as if they were in the room with me, but not actually physically in the room. So we're just beginning that research. So I'm excited about that. But
That's
that was
fantastic.
really stemmed from COVID-19, and how else do we teach students in the way we used to? So it's rethinking.
A great example, Jody.
Yeah.
Okay.
All right. And so launching in then to the findings of our review. So I'll kind of take you at a high level over what we found as well. And then we'll ask a little more from you as the audience in terms of participation. So in our review, we included a total of 26 studies. Just under half of these, about 12, were from the United States. I believe there was one included from Canada and then other places as well. So 16 of these 26 studies were either randomized controlled trials or equivalence trials. And across studies, there was high heterogeneity in almost every study characteristic. So the length of total patient follow-up, for example, was quite variable. Study duration lasted between 1 and 52 weeks, so quite a span. The average, though, was about 3 to 6 months for patient follow-up. And then the duration of the intervention itself lasted on average 6 weeks to 6 months. So this was how often or the length of time that patients were exposed to the digital health intervention for. Interventions were also heterogeneous in terms of the frequency and length of contact. So one study, for example, in particular, reported only one single 90-minute digital health contact, and that was the extent of the digital health intervention for that group of patients. Others reported up to daily contact for 12 weeks. So that dose that we're talking about of patients getting for their digital health intervention was quite variable. And then the actual digital health interventions employed. So some were completely synchronous. And by synchronous, I mean real time. So an example could be, as we're doing right now, like a video call. So connecting in real time with a clinician in a healthcare setting, for example, and a patient at home. Others were completely asynchronous. So non-real-time interventions. This includes things like store and forward technology. So patients could be at home, logging data, taking wound photos, entering information in patient diaries, for example. This information is then forwarded to a clinician and it's reviewed at a later time. So in summary here, under the umbrella of nurse-led digital health intervention studies for chronic conditions, there exists considerable heterogeneity in terms of how these studies are designed and implemented. So that was our first finding. And then what did these studies actually look at? So our included studies examine the effect of digital health interventions on a range of outcomes or primary endpoints. These included outcomes such as lab values, an example being glycosylated hemoglobin, quality of life measurements, patient-reported symptoms, and knowledge and management of chronic conditions. So in applying digital health, nurse scientists were aiming to affect, again, a broad range of outcomes for patients. And so surprisingly at first, 19 of our 26 studies reported an effect on the primary outcome, meaning that the intervention was effective. And then on closer examination, 7 of these were either underpowered or did not include a power analysis. So we recommend just interpreting some of these results with caution. And so in our initial dive in to the results, we first examined the results to explore if studies that were more effective showed patterns in terms of the characteristics of the study themselves. So the type of intervention employed, how often the intervention was delivered, or how long patients were followed up, as an example. And perhaps not surprisingly, due to the heterogeneity across studies, this initial data exploration revealed no immediately obvious patterns. So we did not find, for example, that studies that followed patients for a certain length of time, or where the dose of the digital health intervention was within a certain range, were more effective necessarily than others. So there weren't characteristics across studies that showed that. And what that means to us is that effective nurse-led digital health studies, of which there were many, can actually take on a range of characteristics. And this, probably depends on the aim of the digital health intervention, the population that it's employed with, and so on. So after that just brief overview, I'll pause for a second while we consider our next discussion question.
Yeah, and so based on what Marissa's shared with everyone, we are curious to see where you think nurse scientists fit and where you think nurse scientists have a role in leading this research, and whether you're working with grad students who are doing this work, whether you have this expertise in your schools of nursing.
I do see a comment in the chat as well. Thank you, Eric. So some strong barriers disappeared because of the pandemic. Example, physician resistance related to virtual care associated with fee-for-service system. This opened many possibilities for innovation. And I would have to agree. I think that the pandemic in some ways kind of forced people's hands, perhaps those that were resistant to implementing virtual care or digital health interventions, kind of got swept up in the wave, and that's the way that we deliver care in some instances now. Anyone else like to make a contribution about
Particular gaps that you see, roles?
Yeah.
Mm-hmm. Okay. So when we were linking through the findings that Marissa just walked us through, we were really committed to this idea of how we can frame them more broadly. And in recognizing that CASN has a strong doctoral education framework readily available, we wanted to use the domains of that framework to interpret our findings and to pose some recommendations. So the doctoral education framework from CASN provides guidance to Canadian universities responsible for educating nurses at the PhD level, and emphasizes the knowledge, skill, and experience across each of these domains. We wanted to see how our findings fit within these domains and the broader implications of these recommendations and how it may fit for nursing. And so in thinking through each of them, we're going to walk through the recommendations we came to from our findings. And so that first domain relates to the knowledge, and that refers to the theoretical, the conceptual, and the factual content that's taught and learned in nursing grad programs. So what we found was that studies in our review largely drew upon theoretical knowledge of nursing, and this included psychology, education, and this was in order to provide the important scaffolding in the design and the conduct and interpretation of digital health research. It was within this knowledge base that nurse-led studies in this review looked at things like the complexity of chronic disease, or how they came to select the patient-important outcomes, such as functional status or quality of life. However, from the included studies in our review, only 3 actually followed up past the 26 weeks. And so we saw that as something that maybe contributed to some of the challenges that studies reported. Considering well understood research on behavior change and recognizing that a lot of chronic disease management is based in behavior change and self-management, it's recommended that nurse scientists really look to build upon the theoretical and the factual content knowledge they possess and actually translate that into an alignment of the duration of the study follow-up, thinking through some of the outcomes of interest. And so this could translate to longer follow-up periods, assessing participant needs at midpoint in the study, as well as building in strategies to actually maintain engagement with the intervention throughout the time period.
And so the second domain of the CASN doctoral framework, which is research and evidence, this refers to building the skills necessary to design, lead, and mobilize rigorous and innovative health research. So within the included studies in our review, many were rigorously designed and executed, and this lent credibility to the results generated. So for the reader who could assess the methodological quality, again, we had confidence in the findings of these studies. However, a common flaw among those studies that were included that were perhaps methodologically weaker was that many were actually underpowered to detect an effect on the primary outcome. So of course, without sufficient power, the conclusions drawn by researchers run the risk of being discredited due to flaws in the actual study design rather than in what's showing up in the data. So with this in mind, our recommendation is a robust education strategy for nurse scientists in research trial design and conduct. So this means being able to design trials that have the ability to detect an effect on the primary outcome by sufficiently powering them and other research trial designs. And in tandem, sufficient education for nurse scientists in pilot and feasibility design. So when to apply these types of study designs and appropriate outcome measures for these types of designs. And this will allow nurse scientists then to select the appropriate study design for their outcome of interest and report results with confidence. So making a greater impact by nursing on the science in their field.
The third recommendation we pose is aligned with the third domain from the framework, and that speaks to the importance of all of the roles that nursing enacts. So thinking through the emphasis on practice-based nursing care, there's really an interesting and quite unique opportunity for nursing to not only develop expertise in research and research methodology, but to also intentionally bridge the clinical content areas that we become experts in into this research. And so in embedding this, we add context, connection, and ultimately can yield important practice insights that contribute to stronger research studies. It's understood that digital health technologies do not and will never replace genuine care and concern for patients. And for this reason, and because it's an opportunity for nursing as research and practice experts, it's recommended that nurse scientists are educated to walk that razor edge and design interventions that deliver authentic support and that also keep patients and caregivers at the center of the work that's being done. And so nurses in clinical practice may apply this by structuring high contact programs where regular follow-ups and check-ins are encouraged. In research programs, it's possible that the modality of the contact itself doesn't matter so much as the participant feeling or the patient feeling that they're cared for and looked after. In one of the studies that we examined, both the intervention and the control group actually experienced improved depressive symptoms, and it was posited that it was because they were being connected with on a regular basis, regardless of what intervention or control group they were in. And so, building on our clinical practice knowledge, there is an opportunity for nurse researchers to employ accessible and low-cost means to contact patients. So messaging, telephone, in their digital health research in order to increase that nurse dose and ultimately improve patient-centered and patient-driven measures.
So our fourth recommendation aligns with the fourth domain of the CASN framework, which is communication and collaboration. And this emphasizes the relationships that exist between the nurse and the healthcare team, the client, the community, and other stakeholders as well. So to this end, what we want to emphasize here is the importance of co-designing digital health interventions alongside patient partners and other health system stakeholders. So within our included studies, there were few that talked about having a co-design process or having significant, meaningful patient partner or other stakeholder input into the digital health intervention. However, we know from the literature that co-design of interventions in general, and in particular in digital health, can help to increase their relevance, reach, and acceptability. So by co-creating this knowledge and including patient and community partners in research, we can, achieve outcomes such as formulating patient-important research questions, designing research that meaningfully impacts outcomes and health systems, and as well to mobilize study findings and help to disseminate that work among patient and stakeholder communities. So our recommendation here is that nurse scientists build and sustain relationships with patients and stakeholders to implement these practices. And this is, again, in order to increase the relevance, reach, and acceptability for patients and stakeholders of these digital health interventions once they're employed in practice.
And our last recommendation combines the remaining two CASN domains, thinking through professionalism and leadership. And so within these domains, accountability, ethics, the values of nursing as planetary health leaders are included. Studies in our review highlighted the significant opportunity that exists in healthcare systems to employ advanced practice nurses in education and in programmatic development in order to support clients, enhance quality of care, and decrease cost burden. So while studies in this review were led by nurse scientists, few actually spoke to the scalability or to the future implementation of the research that was conducted. And more specifically, few spoke to clinical practice. And so it's recommended that in thinking through nurse science and how we educate nurse scientists, that digital health intervention science really does consider pragmatic research designs that incorporate real world conditions, patient important outcomes, all in the spirit of aiding successful spread. The pragmatic development of digital health interventions, incorporating patient and community partners, would also help to emphasize those patient important outcomes and ultimately help in the design of robust studies that contribute to research with greater impact on health outcomes. And so in total, these were the recommendations that came from our findings. And maybe not shocking recommendations, things that we think that there are gaps in our current health, in our current education system. And so with that, we had one sort of final question for us to think, and then we wanted to open it up to answer questions from you all. And so thinking through the recommendations that we've put out, are there other recommendations that nurse scientists should consider when designing these digital health interventions? And so I'm actually going to stop sharing, and that way I can see if people are commenting or whatnot.
I'll just highlight from the chat a little while ago. So Jody's left us a comment here that IT and health systems often have not invited nurses to the tables for innovation, and that nurses may not feel comfortable perhaps not having competencies in this area, so nursing informatic competencies. And I see this as very true. So both Carly and I come from clinical backgrounds. And certainly in my experience as well, many of the digital health innovation projects that were rolled out in my health system had physician champions and others, perhaps not always having nurses at the table or at the table in as strong a presence as probably would be needed to roll these out effectively. And please feel free to pick up on others' comments as well. I think that's a really interesting point that, you know, I think it's a chicken and the egg thing, right? Nurses are maybe not developing competencies in this area because we're not being invited to the table, and then vice versa. So again, how do we strengthen nursing education to develop these competencies and really put nurses at the forefront of digital health innovation?
Mm-hmm. I think in preparing for this, Marissa and I have had some conversations and discussion about this idea of that merger, that, you know, chronic disease prevalence is increasing. We've got this really fantastic field of digital health moving along. Nursing has to sort of harness and say, we can merge these two things and we can actually make really important contributions here because of our knowledge and experience and skills. It was a bit eye-opening, I think, for both of us in doing this review, how few studies there were and in what was found in those studies.
Mm-hmm. Yeah, absolutely. I think it speaks to the point that, you know, digital health interventions are going to be studied. This research is going to happen, and it's just, you know, how do we get nurses to the forefront of this movement? Because we know that in many cases, nurses are the right people to be leading clinical care, to be innovating within our health system. It's just giving them the opportunity and tools to be able to do that.
That was one of my questions for you. I think you maybe have answered it, but what was the most surprising thing that you found along this journey? Was it how low of a number of studies? Was that, you had mentioned that, was there anything else?
I think the other, and maybe surprising, maybe harsher, was disappointing, but that only that one study was from Canada.
Yeah.
I hold the nursing science in Canada to a very high standard, and maybe I naively assumed that there was going to be more studies there. And we recognize that our inclusion criteria and our exclusion criteria may have limited those studies. They, in order to be identified as nurse-led or nurse scientist-led, it had to be a registered nurse that we could tell from the first author position on the paper. And so there are some limitations there, but I think that was something that stood out to me as well.
Yeah, absolutely. I agree with that.
Mm-hmm.
I don't know if anybody wants to comment on their last question or just any questions in general for Marissa and Carly.
We are open to conversation.
Mm-hmm.
You talked about the nurse dose. Who came up with that coined that term. I love it. It's catchy.
It is catchy. I think it's actually used more in the United States, and talked about a little bit more there. But we just thought, this idea of how frequently and intensively patients are exposed to nurses and nursing interventions, that nurse dose adequately described that for us.
Yeah, and we were thinking through some of the ambitious outcome measures that were included in some of the studies, and the one recommendation was to lengthen the follow-up, and that was because things like behavior change are just so tough to change and so tough to see in such a short time frame. And Marissa and I were laughing, thinking, if I knew I had to meet with a nurse each week, I might be more motivated to make changes, or I might be more and so thinking about that nurse dose and thinking through what that might mean for individuals with self-management.
Mm-hmm.
Yeah, if you're checking in on my diet and my exercise for the past
Exactly.
week, yeah, I might make better choices.
Right.
Potentially, yeah, for sure.
I guess I wonder what some of the barriers are to nurse-led, not only nurse-led research, but even nurse-led innovations. Like when I think of the opportunity for community health nurses just to be texting with their patients, like what's the holdup there? What's the barrier? Is it they're afraid, like we don't have message systems in place that we can do this, safely and confidentially?
I can speak to that a little bit. I think you touched on a really important point. So, privacy and confidentiality are always at the forefront in any health endeavor. Doing this work or being involved in this work a little bit in my doctoral education has been eye-opening in terms of the real systemic barriers that are in place. So, for us in Canada, an example would just be like procurement. So finding digital health devices and platforms that are approved for use in Canada, being able to have privacy and impact assessments done on them if necessary is not only time, but very resource intensive. And then mobilizing that and distributing it to our patient populations can be tough. The other part of that, the flip side of the coin, is that many of these systems are not designed to talk to each other necessarily. So if patients are accessing services in a variety of different health systems, which many do, getting that data safely, confidentially, and efficiently to other healthcare providers can be challenging as well. I think from my perspective, those are a few of the barriers I would say to nurse-led digital health intervention research.
I think one of the other challenges that I've experienced in the research unit I'm in is this idea of retrofitting existing digital health technologies to suit needs for individuals, and the cost that's associated with that. And so one of the questions in the chat right now is about ethical issues, and to that I can say it's very, very expensive to load some of these programs into our health system here in Canada. Upwards of $100,000 to get the appropriate security checks completed on the systems, and to make sure that there's no risks associated. And so that's one of the big barriers, I think, is cost, and this idea of retrofitting things to fit need to avoid the expensive cost of development.
I think from a health system perspective, that the risks maybe are just too high for them to take at this point. But nurses are going to lead the way. We're going to keep advocating because we know it's the right thing to do.
It really is. It really is. Even things, I was reading a study the other day that was talking about the benefits of just SMS messaging prior to like diagnostic imaging, and how much that decreases missed appointments. Just getting a text reminding you that you have an appointment, and how much that would save our system, and also just increase that forward-facing aspect of healthcare.
Another interesting ethical issue I think that often surfaces in digital health research is about who owns the data. So, and that's one that comes up quite often, I would say. So, you know, as clinicians and as health systems, we are stewards of patient data, and we certainly have obligations to protect it to the best of our ability in terms of privacy and security. But ultimately, by increasing sharing of data among patients and their clinicians, perhaps from different health systems, which is a benefit to digital health, we also for sure increase the risk of, you know, that data being breached to some extent, and or perhaps disclosed to parties that, you know, that aren't or shouldn't be privy to that information. And so it's always a question for us about, you know, this ultimately is the patient's own data. And so are they the ones to give permission-based access? Does that lie with the clinicians? Does it lie with the IT department in the health system? So it's an interesting, I would say, area to try and navigate a little bit in this space.
Yeah, I think COVID has propelled it, because they always said there's no way you can do virtual care, and look at us now.
Right,
Right?
exactly.
So,
yeah, you must. Yeah.
So I think, yeah, it's an opportunity.
Yeah.
There's something else in the chat there. I'll let you read.
Oh, sure. Yes. Right. So I'm from Ethiopia, and digital health is gaining emphasis and found to be effective in the area of TB/HIV and maternal care, especially in remote care access.
Mhm.
Certainly,
I think some of the barriers we have here in Canada ourselves are rural and remote communities and equity. And it would be fantastic to see more emphasis on how we can bring excellent care to every person that's in our country through digital health means. And again, I think COVID has really pushed that forward and said we can and we should and we will. But yeah, it's a great point.
We're nearing the end of the hour. Are there any final comments or questions for Carly and Marissa? Feel free to come off your mute.
Thank you for attending.
Mm-hmm.
Okay, well, I guess if there's no further questions right now, if you think of something, I'm sure Marissa and Carly are open to your feedback or your questions, and their information will be posted both on the YouTube CASN channel, as well as you will get a recording of this in follow-up. And maybe Christine, if you have any final words, you or Sabiha?
I just wanted to jump in and say thank you again for this really interesting presentation, and to congratulate you on the publication.
Thank you. Thanks for having us and spending your time with us.
If you want to continue the conversation, we do have the CASN Digital Health Interest Group. So we are a new group to CASN. We started last year, but then kind of got set back with COVID. So we are still a relatively new group. So we welcome new members. So just connect with Christine if you're interested.
Oh, and Dr. Baker, CASN's executive director, has her hand raised. So Cynthia, you're unmuted.
Okay, great, thanks. Whoops, I just wanted to say I really found that very timely, very interesting presentation. Thanks very much for it.
Oh, you're so welcome.
Thank you.
Thanks for attending.
Okay. Well, thank you all so very much. Thanks to CASN for hosting us. And we are happy to continue the conversation if you're interested in the future.
Yeah, absolutely.
Hey, happy holidays all.
Yes, you too.
Take care, everyone.
Bye now.
Bye.